Headache and migraine. Headache is a symptom of pain anywhere in the head or neck. There are more than 200 types of headaches. Some are harmless, some are life-threatening. Headache is the most common reason patients seek medical attention on a global basis, being responsible for more disability than any other neurological problem. Yeah, this is going to be our approach, clinical approach. My approach today will be based on the international classification of headache, wherein the international classification of headache disorders characterizes headache as primary headache disorders or secondary headache disorders. I feel this is the best approach, a best clinical approach to a person suffering from headache. So we divide it either as a primary headache or secondary headache. This is according to the international classification of headache. But what exactly is primary headache and what exactly is secondary headache? Primary headaches are those in which headache and its associated features are the disorder itself. They are benign, recurrent headaches, that is with treatment or without treatment, they are going to subside only to come back again and not caused by underlying disease or structural problems. Example, tension type headache and migraine. So primary headaches, there's no cause at all. We actually do not know why these headaches come. There is no underlying pathophysiology like tumor, like infection, like aneurysm, rupture. We don't have any cause, but still the person gets headache. This is primary headache. No reason whatsoever. Again, there are many types like tension type headache, migraine. Another characteristic feature of primary headache are they are recurrent. They subside with treatment or without treatment only to come back again. Migraine you treat, you prevent, but they do come again also. Tension type headache, they may come again also. And they are benign. You need not worry at all. Though the headache may seem incapacitating, they are benign and not at all life-threatening. So once you have worked up the case and you know that there are no causes with MRI brain and with LP-CSF functions, CSF analysis and ESR-CARP to rule out temporal arteritis, you're sure that there are no underlying causes. You can be happy because it's going to be primary headache. You need not worry at all. What you have to worry, what is going to cause us concern is secondary headache. But what exactly is secondary headache? Secondary headaches are those caused by exogenous disorders. They are caused by an underlying disease like an infection, like meningitis, bleed like subarachnoid hemorrhage or tumors. Secondary headaches may be dangerous. So our approach to a person having headache is basically to find out whether it's a primary headache or a secondary headache. Primary headache, there's no cause. Despite extensive evaluation, they are benign, not at all dangerous. They are recurrent. Secondary headaches are dangerous headaches. They definitely have a cause like brain tumor or subarachnoid hemorrhage. They are progressive in nature. They're going to worsen and they are sometimes life-threatening. So this is the best clinical approach based on international classification of headache. We divide it into primary headache and secondary headache. Yeah. This is the international classification of headache disorders, ICHD 3 beta version. So according to this, headaches are divided into 3 parts. One is primary headache, second is secondary headache, and third is neuralgias, painful neuropathies like trigeminal neuralgia. So primary headaches, as I said, there is no cause, benign, recurrent. And the important 4 categories of primary headache are migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headaches. So the important categories of primary headache are migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headaches. The important categories of secondary headache where there's a definite cause and it may be dangerous and it is progressive in nature are 1. Headache attributed to trauma to the head or neck, headache attributed to cranial or vascular disorder, headache attributed to non-vascular intracranial disorders like raised intracranial idiopathic intracranial hypotension or spontaneous intracranial hypotension, headache attributed to substance or its withdrawal, headache attributed to infection like meningitis, headache attributed to disorder of hemostasis like hypercapnia, increased carbon dioxide, headache or facial pain attributed to the disorders of cranium, neck, eye, nose, sinuses, teeth, mouth or other structures like cervical structures, and headache attributed to psychiatric disorders. So headache can be divided into part 1 primary headache, part 2 secondary headache, and part 3 is painful cranial neuropathies, other facial pains and other headaches, painful cranial neuropathies like trigeminal neuralgia and other facial pains and other headache disorders. Right. So my stress is always when I approach a person with headache is to find out whether it's a primary headache or secondary headache. But what exactly can give me clues whether it is a primary headache or secondary headache? The American Headache Society recommends using SNOOP as a mnemonic to remember the red flags for identifying a secondary headache. So when a person comes with headache, always look for this SNOOP, SSNOOP. They are red flags. If they are present, it indicates a secondary headache disorder, and you have to be really careful because they are going to have definitely a cause. It may be life-threatening, and you need to be really worried about. So what is the SNOOP? Yeah, these are the red flags indicating whether it is a secondary headache or not. 2S, one is systemic symptoms. If patient has got fever, weight loss, fatigue, or there are secondary risk factors, you have to think of secondary headache. Examples are infections, inflammations, metastasis, or carcinomatous meningitis. So obviously they have systemic signs like fever, weight loss, and other symptoms. Second is if they have neurologic symptoms or signs. Person may have altered consciousness like meningoencephalitis or brain tumor hitting on the temporal lobe or the frontal lobe, or focal deficits. They may have aphasia if it is a left frontal or left temporoparietal lobe is involved. So again, you have to think of encephalitis, mass lesions like tumors or stroke. So if they have systemic symptoms, secondary risk factors, neurological signs, you have to be worried. And the other 2 O's are onset. If the person is all right, absolutely all right, sitting and talking to me, suddenly he develops severe excruciating headache, you have to think of subarachnoid hemorrhage, abrupt in onset, thunderclap. Subarachnoid hemorrhage, that they have severe excruciating headache, but surprisingly, they do not have neurological deficits. Surprisingly, they will not have neurological deficits. Why they don't have neurological deficits? Because the blood is in the meninges only, subarachnoid space. It has not gone into the brain. Unless the brain parenchyma is involved, you will not have neurological deficits. So since it's confined only to the subarachnoid space, you'll have only pain. So a person who's absolutely all right suddenly develops excruciating pain, sudden in onset, without neurological deficits, you have to think of subarachnoid hemorrhage. Onset is very, very important. The other is for older. If a person is older than 50 years, always suspect temporal arthritis. Temporal arthritis, you need to suspect if a person is older than 50 years and comes with headache. And the best test we do is ESR and CRP. Why is it important to always suspect temporal arthritis? Because when the temporal arthritis is there, it can affect the ophthalmic artery and patient may eventually develop blindness. So to prevent blindness, you have to suspect, diagnose, and treat temporal arthritis. The classical clinical finding they come with jaw claudication. They start eating, but after eating for some time, they develop severe pain. The jaw muscles get affected, they develop severe pain. If the jaw claudication is there, the pain in the temporal region, age more than 50 years, ESR, CRP elevated, always suspect temporal arthritis. And when you give steroids, they become better. So one of the treatable conditions of secondary headache is temporal arthritis. So the person becomes better. You're going to save him from losing his sight, his vision. So always suspect a person with in older age group, elderly age group, temporal arthritis. Then P, very important, positional. A person is all right when lying down, but the moment he sits up, he develops severe headache. It is because of intracranial hypotension. The CSF is draining out because of gravity, and they develop severe headache. Classic example is post-lumbar puncture headache. The moment you take the CSF out, the CSF comes down, and when they sit up, because of the gravity, the CSF goes down, they'll develop severe headache. Spontaneous intracranial hypotension. On the contrary, they may have idiopathic intracranial hypertension, which is also because of the pressure changes in the CSF, they'll develop severe headache. In fact, the pressure changes, the positional changes will cause headache. For example, if they are going to lie down and start tying their shoelace, they develop severe headache. So any positional change which gives rise to headache, always suspect something to do with the CSF dynamics, either spontaneous intracranial hypotension or idiopathic intracranial hypertension. Idiopathic intracranial hypertension is usually seen in women, obese women who generally take tetracycline or vitamin A. Cause is not definitely known, but it could be because of the decreased absorption of the CSF. It could be a transverse sinus thrombosis. We have to be very careful because they'll have papilledema. So you can do optic nerve fenestration, or you can do VP shunt, ventriculoperitoneal shunt, or you can give a drug called as acetazolamide, which decreases the CSF production. So positional changes to do with CSF dynamics, either idiopathic intracranial hypertension or spontaneous intracranial hypotension. The classic example is lumbar puncture headache. When you take the CSF out, they may develop severe headache. Then what you have to do as a treatment is autologous blood patch. Take the person's own blood and put it on the place where you have done CSF analysis, the site of CSF analysis. It covers the tear, and then the person's headache will come down. So positional change is very important. Prior history of headache is important. A person who's got headache is okay. Suddenly there's a change in the quality of headache. A person who is having a normal mild headache suddenly becomes severe headache. A person with headache develops positional changes. So a change in the pattern of the headache, always suspect a malignant process, a secondary headache, a different in quality. Papilledema. Papilledema, as I said, raised idiopathic intracranial hypertension, they'll have papilledema. So any person with headache, we need to check the eye. We need to check the fundus. Papilledema, raised idiopathic intracranial hypertension. Previously, it was known as pseudotumor cerebri. As I said, the CSF raise could be because of the decreased CSF absorption, because of the arachnoid granuli or transverse sinus thrombosis. They can put even a stent in the transverse sinus. Or you can do optic nerve fenestration or ventriculoperitoneal shunt, or you can give acetazolamide to decrease the CSF production. And very classic history is visual obscurations, as you can see in the slide, visual obscurations. They'll have transient visual obscuration with change of position. In fact, a very good history what is forthcoming is that a person, when he bends down to tie the lace of his shoe, he'll have severe headache. It's absolutely normal. Suddenly he bends down to tie the shoelace, he gets headache. You have to suspect again idiopathic intracranial hypertension. So this is a wonderful mnemonic created by American Headache Society, SNOOP. 2SNOOP. S for systemic symptoms, secondary risk factors, N for neurological symptoms and signs. O is sudden onset, older people, positional changes, the sudden change in the quality of headache with prior history of headaches, and papilledema. Right. Now let me tell you a very, very important and interesting concept, the pain-sensitive structures. Very fascinating is that brain does not have pain-sensitive structures at all. Brain does not have pain-sensitive structures at all. You cut brain, there is no pain. You cut brain, there is no pain, because brain is insensitive to pain. It is only the coverings of the brain, the meninges, and the vessels on the meninges which are pain sensitive. And therefore, if a person develops headache, it is to do with meninges or meningeal vessels. That's why we get headache in subarachnoid hemorrhage, because meninges are involved. But we don't get headache in a stroke, cerebral infarct, or cerebral hemorrhage unless there's a raised intracranial pressure where meninges are involved. So brain per se does not cause headache. If there is an intracranial pathology like brain infarct, person does not come with headache. But subarachnoid hemorrhage, because the meninges are involved, patient comes with headache. Likewise, meningitis, infection of the meninges are involved, which are pain sensitive, they present with headache. So even migraine, they present with headache. Why? It's a trigeminal vascular structures affecting the meninges, coming from the trigeminal nerve and then going to the vessels and the meninges. So only the meninges and the vessels are involved, you'll have headache. They are pain sensitive structures. Brain is insensitive to pain. A wonderful sentence made is that you cut brain, there is no pain. So the brain itself is not sensitive to pain, but because it lacks pain receptors. However, several areas of the head and neck do have pain receptors and thus sense pain. These include meninges, vessels, cranial and spinal nerves, head and neck muscles. Headaches often result from traction to or irritation of the meninges or blood vessels. Right. Now, as I said in the beginning of my lecture, this is the best approach, whether it is a primary headache or a secondary headache. First, we shall discuss the primary headache, that is tension type headache, migraine, cluster headache, and other primary headaches. And then we shall go to the secondary headaches. So we shall start off with the primary headaches. Primary headache, 90% of all headaches are primary headaches. 90%. So if 100 patients come with headache, 90% are absolutely not at all, you need not worry at all. They are primary headaches. They are not at all dangerous. They are benign. Only 10% are due to secondary headaches. So the moment a person walks into your consultation room with headache, you need not worry at all. Because given an average statistics, 90% of the patients have primary headache. So if 10 people you take, 9 people are having only primary headache. Only one person can have secondary headache. Primary headaches usually start when the people are between 20 and 40 years old, in the middle age group. And therefore, do not suspect primary headache when person usually crosses 40 years, because most of the time the migraine comes in this age group, 20 to 40 years old, and more seen in women. So the primary headaches are usually migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headaches. So migraine is unilateral, pulsating, accompanied by nausea or vomiting. Tension type headache is bilateral band-like pressure on the sides of the head, usually without nausea or vomiting. And third category is trigeminal autonomic cephalgias, and then we have other primary headaches. Yeah, migraine. This is a wonderful rule. Actually, I tried to coin this rule of 4-3-2-1 to diagnose migraine. But what is migraine? They are recurrent headache attacks of moderate to severe intensity with a duration of 4 to 72 hours. That is 3 days. Books give it as 3 days. So you convert, books give it as 72 hours. You convert it into 3 days. And normal physical examination and no other reasonable cause for a headache. So the diagnosis of migraine is easy. Always remember rule of 4-3-2-1 rule. The duration is 4 hours to 3 days. That is 72 hours. At least 4 and 3 are over. What is 2? 2 of the following features: unilateral pain, throbbing pain, aggravation by movement, moderate or severe intensity. So they should have at least 2 of these following symptoms: unilateral pain, throbbing pain, aggravation by movement, and moderate or severe intensity. Aggravation by movement is very, very important. Migraine patients, the headache worsens with movement. That's why they prefer to go silently and sleep on the bed. They sleep silently on the bed without any movement, because movement aggravates the pain. Just the opposite of cluster headache. Cluster headache cannot sit still. They have to pace around. Only when they pace around, the headache comes down. Again, very interesting differentiating point. Migraine patients, the headache worsens with movement, and therefore they completely take rest. Cluster headache, when they pace around, only the headache comes down. Headache comes down, and therefore they keep moving around. Plus, at least one of the following features: nausea, vomiting, or photophobia and phonophobia. So this is the diagnosis of migraine, a very simplified rule of 4-3-2-1. 4 hours to 3 days, 2 of the following features, and at least one of these following features. Yeah, migraine. Migraine attack has 4 phases. The premonitory or the prodrome phase, there'll be mood change, they become dull, irritable, they can have neck discomfort lasting from few hours to days. This is the premonitory or prodrome phase. Aura is not seen on all migraine patients. It is seen in about 20 to 25% of migraine patients, but if it is present, it highly suggests migraine. What is aura? Basically, they'll have visual disturbances. It is because of the cortical spreading depression coming from the occipital lobe going anteriorly. So since occipital lobe is affected, they'll have visual symptoms: flashing lights or zigzag line moving across the visual field, scintillating scotomas. And how do you differentiate whether it is an occipital lobe infarct or it is a migraine coming from the occipital lobe? Because both can have visual disturbances. Migraine is a cortical spreading depression coming from the occipital lobe and slowly coming to the frontal lobe. So it does not respect arterial territories. Very important point. It is not confined to posterior cerebral artery. It moves around even forwards. Unlike posterior cerebral artery involvement, where it is confined to posterior cerebral artery. So to differentiate an occipital lobe infarct from migraine, migraine does not confine to an arterial territory. Occipital lobe is confined to an arterial territory like posterior cerebral artery. And it is sudden in onset, where this is gradual, it builds up. 4 hours to 72 hours. So these are the important clues to differentiate whether it's migraine or any other stroke patient. So aura is seen only in 20 to 25% of migraine patients, and typically it is a visual aura because the cortical spreading depression comes from the occiput lobe and then comes forward. And then after this, we actually have the headache phase. Pain is associated with associated structures like nausea, photophobia, phonophobia, allodynia. Allodynia is non-painful stimulus appearing painful. One more important point, one more important concept with migraine is that they have nausea and vomiting. And during the acute attack, they may have gastric paresis. Gastric paresis. Because of these two reasons, we give dopamine antagonists, because one of the core treatment features of migraine is giving, along with non-steroidal anti-inflammatory agents, triptans, we give dopamine antagonists. The question may be asked, why is dopamine antagonist given in migraine patients? Two reasons. It can prevent nausea, vomiting. Second, there's gastric paresis, gastric stasis. When there's gastric stasis, when you give drugs, it cannot be absorbed. There's impairment in absorption of the drugs. And therefore, to overcome the gastric paresis, we give dopamine antagonists, one of the important cornerstone treatment of migraine. And then the postrum, they appear tired, they have impairment of the concentration. So migraine has typically 4 phases: the premonitory or prodrome phases, where they can have mood changes, aura seen in 20 to 25% of the patients, especially visual aura, headache phase with nausea, vomiting, gastric paresis, and postdrome phase, where they seem to be tired and confused also, right? Headache suggestive of migraine for more than 15 days per month for more than 3 months, we call that as chronic migraine. Right. This is probably a very, very important point. Why? The common types, the commonest cause of headache, 90% is primary headache. And in the primary headache, the commonest 2 disorders causing primary headache are tension type headache and migraine. The trigeminal autonomic cephalgias or other primary headache disorder form only a small percentage. So 90% of the headaches are due to primary headache, and most of the causes of the primary headache are either because of tension type headache or migraine. Very difficult to differentiate sometimes whether it is tension type headache or migraine. But there are 2 ways, 2 important points by which we can differentiate whether it's migraine or tension type headache. Migraine at its most basic level is headache with associated features. So a person having headache with nausea, vomiting, photophobia, phonophobia, these associated features is suggestive of migraine. Tension type headache, it is just basic headache without any associated features, without any neurological deficit. Very, very important. So migraine at its most basic level is headache with associated features, and tension type headache is a headache that is featureless, only headache. And second important point is that tension type headache is mild or moderate, but most patients with disabling headache probably have migraine. If a person says, sir, I've got headache, but I'm able to go to my office and able to do my job or go to a college and attend my class, most probably suffering from TTH, tension type headache, because they are mild and moderate. But if the person is having doctor, I'm having a disabling headache, I'm unable to bear it, real excruciating headache, I want to sit quietly, lie down, unbearable, think of migraine. So 2 features by which you can differentiate migraine from tension type headache is that migraine is a incredibly excruciating headache, severe headache, whereas tension type headache is a mild to moderate headache. Second, migraine will have associated features like nausea, vomiting, photophobia, phonophobia, whereas tension type headache is headache which is featureless. Yeah, there are certain triggers of migraine. Persons can then they'll understand that certain triggering factors are there which worsens their migraine. What are they? Glare and bright lights. They should not see bright lights, glaring lights, looking at sun, walking in hot sun. Sounds, even you might have heard, you listen to some 3-4 songs with big sound making a lot of noise, you get headache. Hunger, you should, even if you want to be careful with your diet, fine, but take 3 times a day, take a small quantities, but don't skip breakfast or don't skip dinner, because hunger itself can worsen migraine. Let down from stress. If you are stressful, you will have headache. Hormonal fluctuations, especially seen in women during menstruation, hormonal fluctuations during menses. Normally, we require about 8 hours of sleep a day. That is, out of 24 hours, 1/3 of the time we spend on sleep. Lack or excessive sleep also is a migraine trigger. Alcohol, especially alcohol, not only triggers migraine, it also triggers cluster headache, and chemical stimulants like nitrates. So these are all the migraine triggers, and we should always ask these conditions, and if they are present, ask them to avoid all these triggers. Yeah, this is a wonderful diagram. This is well given in as a review article in New England Journal of Medicine. So the sensory sensitivity that is characteristic of migraine is probably due to dysfunction of monoaminogenic sensory control systems located in the brainstem and hypothalamus. So you can see here the vessels coming to the trigeminal nerves, the meningeal vessels coming into the brainstem and going to the thalamus, from there to the cortex. So what exactly, how do they happen? The nociceptive transmission originates from the activation and sensitization of first order trigeminal vascular neurons. Their cell bodies are in the trigeminal ganglion, and their afferent fibers innervate the meninges and its vessels. Again, a very important point. As I said in the beginning of the lecture, brain is insensitive to pain. Unless the meninges and its vessels are involved, you will not develop headache. So that's why you see headache in subarachnoid hemorrhage, meningitis, and migraine, because the meninges are involved. Ascending nociceptive transmission from the trigeminal ganglion is projected to the brainstem, activating and sensitizing secondary order trigeminal vascular neurons, including those in the spinal trigeminal nucleus. These in turn activates and sensitizes the third order trigeminal vascular neurons in the thalamus, which subsequently relays the nociceptive transmission to the somatosensory cortex and other cortical areas, ultimately resulting in the perception of migraine pain. Yeah. So how do we treat migraine? Basically, we have two types of treatment, two types of management of migraine. One, the treatment per se, known as abortive treatment. Second is prevention of treatment. Very important. I again repeat, I emphasize that management of migraine has got two components. One, the treatment of migraine per se, that is, you're trying to bring down the pain of migraine. The treatment or the abortive management of migraine. Second is the prevention of migraine, because they are recurring, they are benign recurring type of attacks. So you have to give pharmacological agents which help in the prevention of the recurrence of the migraine. So two management strategies: one, treatment or abortive treatment; second is prevention. The abortive treatment again has got two components. One is the non-pharmacological management. Second is the pharmacological management. The non-pharmacological management, you ask them to quieten down. The stress, you should not take it too much. In fact, they've done a study, they found that all people experience stress. Who does not experience stress? As a student, you'll be experiencing stress to write an exam. As a graduate, you'll be experiencing stress to get a good job. So everyone has stress, but why only some people have migraine, the other people do not have migraine? Those stress is present in all peoples. What they found out, the studies have found out that migrainians are exquisitely sensitive to stress. They overtly react to the stressful situation. That's what precipitates migraine. So stress is present in everyone, but they are oversensitive and overtly react to the stressful situation, and that precipitates migraine. So non-pharmacological treatment asks them to calm down, have a stress-free life. In fact, there's a term known as yoga. Yoga means equanimity of mind. They do not feel elated at success, nor they get depressed at failures. They always maintain equanimity. But is that true that the yoga brings down the stress levels and helps in migraine? Yeah, it is true. It has been documented. In fact, they've done studies on persons who do yoga, meditation, and the persons who are active in their life. When you do EEG normally, we have alpha activity going on. When we do EEG activity, we have alpha activity going on, normally 8 to 13 hertz per cycle. But when they've done this EEG on people who meditate, who calm down, do meditation, and in a state of yoga, the activity comes down, the frequency comes down. It comes to the theta level, 4 to 7. So definitely meditation, yoga, and other ways of bringing down your stress. Walking helps in migraine. Can you believe that? When you walk for half an hour, body starts releasing enkephalins and endorphins. They are opioid-like substances. They will bring down your stress levels because they are endogenously secreted opioids. Exogenously given opioids, people take drugs to get satisfaction, thrill, but they are bad for your health. These are endogenously secreted and they are good for your health. Just walk for half an hour. You feel so happy because body secretes enkephalins and endorphins. So not only walking is good for physical health because it controls blood pressure, diabetes, dyslipidemia, but also it brings down your stress levels and keeps you in an elated state, in a happy state because of the hormones, enkephalins and endorphins. In fact, there is a very nice concept known as happy hormones. Always remember these happy hormones, a non-pharmacological treatment of migraine, for that matter, for any stress. What are these happy hormones? Remember dose, acronym is dose. D is for dopamine, O is for oxytocin, S is for serotonin, E is for enkephalins and endorphins. When do you get this dopamine? You get dopamine when you set a goal and work towards achieving the goal. For example, when you're an MBBS student, you set the goal that you are going to really top the university exam and work towards it. You will get a surge of dopamine. You'll feel so happy. It is known as reward hormones. Once you finish your MBBS, again set the goal that you are going to hit a big specialty and super specialty courses. Work towards it. Again, dopamine gets released and you'll feel happy. So once you set a goal, accomplish it, reset a goal, then dopamine gets released. So that's why people who are really working hard, who are focused in their occupation, generally do not have migraine because they are having these happy hormones, dopamine level, goal-oriented, reward-giving hormone. Second is oxytocin. Oxytocin is a bonding hormone. It is seen when you bond, when you touch your friends, hold on your friends, hug your friends, or bonding between mother and a child. When you bond, you get happiness. In fact, they have proved it, scientifically proved it. There was a study which was conducted in Japan. A lot of people in Japan were living to the ages of 120 and 130 years. So scientists got surprised. Living till 100 itself is difficult. These guys are living till 120, 130 years. What is the reason? When they did this study, a lot of people in that area were born together and were they growing together in the same place. So they were born together and growing together. So they were childhood friends, becoming adults, childhood, then adults together, old age going. So you bond with your people of your generation and you have grown together. So you feel so happy talking to your childhood friends. Don't you feel so happy talking to your childhood friends, your school friends or your college mates? Same thing happens. So they were born together and grown together. So they're sharing excellent bond. Oxytocin gets released. They felt happy and they were living till 120, 130 years. Then third is the serotonin. You get this hormone released when you walk in the nature, when you walk in the sun. You can walk on the treadmill and gym, good, but it gives you good physical health. But if you want still better, happy situation, you walk in the nature. Serotonin, it is present in the bananas also. So walk in the nature, serotonin gets released. But the best part is walking. In fact, American Heart Association has clearly said that 150 minutes of moderate exercise per week, you will get real good physical health and mental health. That means if you walk for 30 minutes a day, just 5 days a week, you get 150 minutes, and then you're feeling very happy. It's good. So when you walk at least 30 minutes a day, body starts releasing enkephalins and endorphins, which gives you happiness, endogenously secreted. You exercise, you swim, you work out, you play a game of tennis, and then come. You feel so happy. In fact, I was always observing that most of the sports persons are happy because they work a lot, they exercise a lot. That's why they're all happy people, happy-going people, very nice people, because they work out, they have these hormones getting released. So non-pharmacological treatment, meditation, yoga, dose. D for dopamine, O for oxytocin, S for serotonin, E for enkephalins and or endorphins. If you want me to pick up any one particular of all these, I'll prefer walking. Walking just half an hour a day is more than sufficient. The pharmacological treatment consists of acute therapies for migraine and preventive treatments for migraine. In general, preventive medication to be considered in patients with 4 or more attacks a month. Yeah. So as I said, the non-pharmacological management, healthy diet, regular exercise, walk at least 30 minutes a day, at least 5 days a week, 150 minutes per week. Regular sleep pattern, you should sleep at least 8 hours a day. I've seen a lot of people not studying, and before the exams 1 or 2 days, they don't even sleep and they keep studying. What kind of memory they'll have? They'll not have good memory. In fact, when you sleep well 8 hours a day, your memory also improves well. There's memory consolidation occurring, especially in NREM sleep. And the best time to study is when you sleep for 8 hours and get up in the morning. The brain is in a very good position to absorb information. Early morning studying, that's what we call it as a memory improvement technique. The best time to study is early morning. When you sleep for 8 hours and get up in the early morning, your brain is fresh and is willing to absorb information akin to a sponge willing to absorb water. They are beautifully compared. The brain is willing to absorb information akin to a sponge willing to absorb water. So early morning studying is best, and have regular excess sleep patterns, avoidance of excess caffeine and alcohol, avoidance of stress. Patients with migraine do not encounter more stress than headache-free individuals, but over-responsiveness to changes in stress appears to be the issue. Yeah, pharmacological treatment, basically there are 3 types. One is the non-steroidal anti-inflammatory drugs like naproxen, 5-HT1B receptor agonist like triptans, CGRP receptor antagonist like gepants, 5-HT1F receptor agonist like ditans. So we have the non-steroidal anti-inflammatory agents, we have triptans, and then the third part I said dopamine receptor antagonist. Because migraine is associated with nausea and vomiting, they are associated with gastric stasis, which impairs the absorption of the drugs which are going to give for treatment of migraine, and therefore they do not act effectively. So dopamine receptor antagonist, drug absorption is impaired during migraine because of the reduced gastric intestinal motility. In addition, they have decreased nausea and vomiting. They have, it decreases nausea and vomiting and restores normal gastric motility. Example is metoclopramide and domperidone. So management of migraine, you give non-steroidal anti-inflammatory drugs. It should be considered as a first-line medication for the treatment of migraine attacks. Non-steroidal anti-inflammatory agent should be considered as first-line management for the treatment of migraine attacks like naproxen. Patients in whom NSAIDs provide no or inadequate pain relief should be offered an oral triptan. If an oral triptan provides pain relief, other triptan should be offered if it does not provide. Combination therapy with naproxen sodium should be offered in patients who have inadequate pain relief with triptan. Ideally, clinicians should first offer subcutaneous sumatriptan when a patient has an inadequate pain relief with all oral triptans. However, subcutaneous sumatriptan may be tried in earlier stage if oral triptans cannot be ingested because of vomiting or if headache intensity peaks rapidly. Ditans and gepants may be considered for patients in whom NSAIDs and all available triptans are ineffective and have unacceptable side effects or are contraindicated. So the decision about when to substitute triptan with a gepant or ditan should be made in accordance with the local practice guidelines. Antiemetic agents may be offered as adjunctive therapies in patients with attacks accompanied by nausea or vomiting. So this is a beautiful algorithm. It is given in NEJM, New England Journal of Medicine review article. So how do we approach algorithm for persons with migraine? Antiemetics for nausea or vomiting, NSAID. If they are contraindicated, go for acetaminophen, that is paracetamol. NSAID is more than 3 consecutive attacks with no or insufficient response to one NSAID, go for triptans. If monotherapy is insufficient, add naproxen. If there are more than 3 consecutive attacks with no or insufficient response to all available triptans plus naproxen, then go for ditans or gepant. Yeah. Now pharmacological management, preventive treatment, prevention of migraine. The 6 categories for prevention of migraine are: 1, the beta blockers, example propranolol; antidepressants, example amitriptyline or nortriptyline. Most of the neurologists have started using nortriptyline; anticonvulsants like topiramate; calcium channel blocker like flunarizine; monoclonal antibodies against CGRP or its receptor, example eptinezumab; botulinum toxin, approved only for chronic pain. So initiation of preventive treatment should be in general considered for patients who have at least 2 migraine days per month and are adversely affected despite therapy. So this is the preventive treatment for migraine. Again, this is given in a very good as a review article in New England Journal of Medicine. I suggest you all to go through that article. There are at least 2 migraine days per month and adverse effects despite therapy for migraine. Then initiate preventive treatment. What are the preventive treatments? Antihypertensives like propranolol; monoclonal antibodies against CGRP or its receptor like adalimumab; anticonvulsants like topiramate, topiramate is a preferred drug; antidepressants, amitriptyline, now nortriptyline; calcium channel blockers like flunarizine or botulinum toxin. Right. This is all about migraine, which is a form of primary headache. So more than 90% of headaches are because of primary headache. And in primary headache, the most common are tension type headache and migraine. So what is tension type headache? It is commonly used to describe a chronic headache syndrome characterized by bilateral tight band-like discomfort. The pain typically will slowly fluctuates in severity and may persist more or less continuously for many days. The headache may be episodic or chronic, that is present for more than 15 days per month. Please note this important point. The presence of associated features are suggestive of migraine, and the absence of associated features like nausea or vomiting, photophobia or phonophobia is highly recommended. TTH is highly recommended. This particular point should be emphasized when you approach a person with migraine and headache. TTH. The pain of TTH, the treatment is NSAIDs. The treatment for chronic TTH is amitriptyline or nortriptyline. Tricyclic autonomic encephalitis, but most important of this is cluster headache. TACs are characterized by relatively short-lasting attacks of head pain associated with lateralized cranial autonomic symptoms such as lacrimation, conjunctival injection, nasal congestion, or oral fullness. The trigeminal autonomic encephalitis include cluster headache, paroxysmal hemicrania, SUNCT, short-lasting unilateral neurologiform headache attacks with conjunctival injection and tearing, SUNA, short-lasting unilateral neurologiform headache attacks with cranial autonomic symptoms. Cluster headache. The core feature of cluster headache is periodicity because it affects the hypothalamus, the circadian rhythm. In fact, it is known as the time clock headache also. Some persons can pinpoint 3:30. The next day also at 3:30, they say they get headache. Same time, 3:30. The next day also 3:30. In fact, the persons may say, now the time is 3:30. Why? Because I've developed headache. Such is the period. Exactly at the same time it occurs because of hypothalamus involvement, because it is an organ for circadian rhythms. And it occurs in clusters in seasons, spring season or some other season, and then they are free. Again, it comes in clusters. So these are the two core features of cluster headache. Periodicity occurs at a particular time, occurs in clusters. Patients with cluster headache tend to move about during attacks, unlike migraines who prefer to remain motionless during attack. Very important, as I said earlier, migraine patients aggravates when they walk. So they quietly sit and then lie down. Whereas cluster headache, they have to pace around, otherwise the headache is not going to come down. Attack frequency is about 1 to 2 per day and lasts for about 15 minutes to 3 hours. So it is short, frequency is more. Males are more affected. Alcohol may trigger or set off attacks, may be nocturnal. It may be more seen in the nighttime. It is associated with ipsilateral symptoms of cranial parasympathetic autonomic activation like lacrimation. The phenomenon of unilateral photophobia or phonophobia are characteristics of TACs, not bilateral. Unilateral photophobia or phonophobia is characteristic of trigeminal autonomic encephalitis. What is the treatment? Again, you have acute treatment, you have preventive treatment. Acute attack of cluster headache, surprisingly, is oxygen inhalation. This should be given as 100% oxygen at 10 to 12 liters per minute for 15 to 20 minutes. Sumatriptan 6 milligrams subcutaneous can be given. The preventive treatment is a short-term prevention, 10 days to 21 days of prednisolone, 1 milligram per kg up to 60 milligrams per day, tapering over 21 days. The long-term prevention is verapamil, which is about 160 to 960 milligrams per day. Paroxysmal hemicrania. The essential feature of paroxysmal hemicrania are unilateral, severe pain, short-lasting 2 to 45 minutes, very frequent attacks, marked autonomic features, ipsilateral, rapid course, and excellent response to indomethacin. In fact, these are known as indomethacin responsive headaches. Most of the primary headaches, other primary headaches, and paroxysmal hemicrania are responsive to indomethacin. In fact, there's an entity known as indomethacin responsive headaches. SUNCT is very rare, unilateral orbital, many attacks, 20 attacks, lasting for just seconds, and they can have conjunctival injection and lacrimation. Characteristics that lead to a suspected diagnosis of SUNCT are the cutaneous triggers. You touch, the headache worsens. Cutaneous triggers, very important. Most SUNCT attacks have cutaneous triggers, such as touching the face or scalp, washing, shaving, eating, brushing the teeth, talking, and coughing. Abortive treatment is lidocaine. Preventive treatment is lamotrigine. Yeah. So primary headache, we have tension type headache, migraine, trigeminal autonomic encephalitis. We have other primary headaches. What are the other primary headaches? Primary cough headache, primary exercise headache, primary headache associated with sexual activity, primary thunderclap headache, cold stimulus headache, external pressure headache, primary stabbing headache, nummular headache like a coin, hypnic headache, new daily persistent headache. Note, these headaches, as the name suggests, are self-explanatory. But the best part of it is that most of these headaches are responsive to indomethacin. So if you are having headache, you tried out all measures, all treatment options. If the headache is not getting control, always give a shot of indomethacin, because most of these headaches are responsive to indomethacin. Yeah, now we'll go to the secondary headache. So primary headaches are not at all dangerous. Secondary headache, you have to be careful. The headache attributed to trauma or injury to the head and neck. For example, a person has sustained head injury. The diagnosis depends largely on the close temporal relationship between a trauma and headache onset, usually within 7 days of trauma. Person has got headache. If an artery ruptures, there's a middle meningeal artery rupture, torrential bleed, it will cause extradural hematoma. If a vein ruptures, it causes subdural hematoma. It goes for a long time. Chronic subdural hematoma is a treatable cause of dementia. So the moment a person has got headache and after trauma within 7 days, always take a CT scan to rule out hematoma. If there is extradural hematoma, clinically the pupil is dilated because of compression, call immediately a neurosurgeon, take the hematoma out. You will feel extremely happy and satisfied because it's one of the treatable conditions of headache. And if you miss out, you're going to regret, because the extradural hematoma, arterial rupture, if the blood is going to really gush in, go and compress the midbrain and brain structures, patient is going to die. If you take the CT scan, find out extradural hematoma, call a neurosurgeon, take the hematoma out, you're going to do wonders to the patient. Patient will be you'll be extremely happy and satisfied because you have saved a patient's life. If you don't diagnose a non-treatable condition, nothing to worry, but you should not miss out on a treatable condition. Extradural hematoma is one of them. Headache attributed to cranial or cervical vascular structures, vascular disorders. The new condition added in this category is reversible cerebral vasoconstrictive syndrome. Headache attributed to non-vascular intracranial disorder, both increased idiopathic intracranial hypertension or decreased CSF pressure, spontaneous intracranial hypotension, are attributable or can cause headache. So this is headache attributed to non-vascular intracranial disorder. Headache attributed to substance or its withdrawal. Headache attributed to infection like meningitis, meningoencephalitis. They can cause streptococcus, hemophilus, Neisseria meningitis. All can cause meningitis and headache. Headache attributed to disorder of homeostasis, especially hypercapnia, increased carbon dioxide. They can have papilledema, they can have headache. Headache attributed to disorders of the cranium, neck, eyes. Glaucoma is one of the important causes of headache. Ears, nose, sinuses, sinusitis, teeth, any bad teeth, mouth, or other facial and structural causes can cause headache. Headache attributed to a psychiatric disorder. And the third category is painful cranial neuropathies. Example is trigeminal neuralgia. Trigeminal neuralgia, if it is seen in young persons, always suspect multiple sclerosis. Trigeminal neuralgia in elderly may be idiopathic. Multiple sclerosis, though it's a central disorder, it can cause trigeminal neuralgia. Trigeminal nerve is a peripheral nerve, but it can affect the root entry zone, which is myelinated by oligodendrocyte. Peripheral nerves are myelinated by Schwann cells. So multiple sclerosis can cause trigeminal neuralgia in young persons. So you have to treat multiple sclerosis. And you give drugs like carbamazepine, phenytoin, and gabapentin. Some of the residents have come and asked me, sir, why should we give anti-epileptic drugs for painful conditions like trigeminal neuralgia? Carbamazepine is an anti-epileptic drug. Phenytoin is an anti-epileptic drug. Gabapentin is an anti-epileptic drug. Why do we give for painful conditions? We give them. It is because they are sodium channel blockers. How does the pain impulse transmit? It gets transmitted from one node of Ranvier to the other node of Ranvier. It jumps and goes. This is known as saltatory conduction. There are a lot of sodium channels accommodated and accumulated at the internodes. So they are responsible for an impulse jumping from one node of Ranvier to the other node of Ranvier. So if you stop these impulse sodium channels, if you are going to block these sodium channels, the pain impulse cannot transfer. So oxcarbamazepine is a wonderful drug for trigeminal neuralgia, herpes ophthalmicus, herpes zoster. Wonderful drug because it's sodium channel blockers. It blocks the sodium channels at the internodes, and therefore it diminishes or abolishes the transfer of pain stimulus from one node of Ranvier to the other node of Ranvier. And then we have other headache disorders. The pearls, now I'm going to tell, History, his story is the cornerstone for the diagnosis of headache type. In fact, for neurology, most of the conditions are diagnosed by history. And some of the conditions are diagnosed exclusively by history. Headache is diagnosed exclusively by history. Sleep, exclusively by history. Epilepsy, almost exclusively by history. So history is the cornerstone for the diagnosis of headache type. His story, just listen carefully to his story. He's telling you the diagnosis. You listen to the patient's history, patient's conditions. He's telling you the diagnosis. William Osler has quoted it a long time back, Dr. William Osler. So his story is the cornerstone for the diagnosis of headache type. If a person comes with a headache, you need not worry at all, because 90% of the headaches are due to primary headache. Migraine at its most basic level is headache with associated features like photophobia, phonophobia, nausea and vomiting. And tension type headache is headache that is featureless. Only they have headache. There are no associated features. Most patients with disabling headache probably have migraine. A person says, I'm having headache, but still no problem. I'm going to school and college. He's probably having TTH. But a person is having such an excruciating headache that he's not able to move out of his home. He's having migraine. So most patients with disabling headache probably have migraine. Although 90% of headache patients have underlying primary headache, it is always necessary to rule out secondary headaches that may be dangerous. Some people may question neurologists when they take CT scan for any person who comes off headache. I encourage people to take CT scan head for any person coming with headache. Because why do we take CT scan? We all know 90% of the headaches are primary headaches. Everyone knows that. But why we do still take CT scan? Because we are worried. We should not miss out a secondary cause of headache. That is dangerous. The missing out of secondary cause of headache is the most common reason why CT scan head is offered for primary headaches. You think it is primary headache, you treat, but then person's headache worsens, he goes to another neurologist, he takes a CT scan, finds a tumor. Then you'll cut a sorry figure. Had you taken CT scan head, you could have diagnosed the patient and probably saved him when you have picked up at an early stage. So missing out a secondary cause of headache is the most important indication to investigate. So though 90% of headache patients have underlying primary headache, it is always necessary to rule out secondary headaches that may be dangerous, and hence diagnosis should be initiated with investigations. In an emergency, CT scan is preferred. However, when there is a suspicion of underlying serious disorder, MRI is preferred. Posterior fossa lesions, it can miss out. So you have to take MRI. In head injury, CT head with bone window is preferred to rule out fractures. A head injury patient, post-traumatic headache, they may have not only extradural hematoma, subdural hematoma, they may have fractures. So always you have to take CT scan head with a bone window which can pick up fractures. In pregnancy, we try to avoid taking imaging, but if you think imaging is necessary, avoid CT scan. MRI is preferred. In pregnancy, CT scan is avoided and MRI is preferred due to radiation exposure. And if the pregnant lady comes with headache, always prefer paracetamol. Do not give aspirin. Paracetamol is preferred in pregnant ladies with headache. When CSF examination is done, always check the opening pressure has to be checked. Opening pressure has to be, and it should be done in a lying position, supine position. If a person sits up, obviously the pressure is going to increase. So in a lying position, you have to do CT scan, check out the CSF pressure. Around 25 centimeters of water is fine. Above that or below that, you have to be careful. Raised idiopathic intracranial hypertension or spontaneous intracranial hypertension. In elderly patients above 50 years, they have jaw claudication. When they eat, they get pain, temporal artery tenderness. You should always suspect giant cell arthritis. Rule out by doing ESR and C-reactive protein. Initiate steroids. You're going to do so much good for the patient because it's a preventable cause of blindness. Fear of missing an underlying secondary cause for the headache is the single most important reason why we investigate headache patients. Yeah, most of the neurology concepts, I have put it in a question and answer format in the book Focused Neurology, written by me, Dr. S. Sreenivas. This is available online from all the leading booksellers, including Amazon. If you are interested, you can buy it online from any bookseller, including Amazon. And most of the concepts of neurology, I have made videos. It is known as, the channel is known as Dr. Sreenivas Medical Concepts. Dr. Dr. Sreenivas, Sreenivas, medical MEDICL, concept CO and CEPTS, where I have more than 11,500 subscribers, more than 3 lakh views, more than 260 neurology videos. In this lecture, I have given an overview of headache. But if you want to know about the subtopics like migraine, the rule of 4321, the international classification of headache, please go to my YouTube channel, Dr. Sreenivas Medical Concepts, subscribe it and share the link so that you get benefited, your friends get benefited. Yeah, once again, I thank Dr. Kishan Rao and White Army for giving such an excellent opportunity to talk us on such a common but very important topic, headache, addressed to large number of students across India, perhaps across the world. Thanks a lot, White Army and Dr. Kishan. Over to the administration. And I think I finished on time. Yeah.
Thank you so much, sir. It was indeed a comprehensive clinical class and the discussion was very useful to us. We really thank you for teaching us and guiding us and taking out your time to support our group. And we look forward to all your future sessions with us. And I would also like to thank all the active participants of this session. Thank you, one and all.
Thank you.
Thank you, sir.